Welcome to the checkup. I'm Maya Goldman, Modern Healthcare's Rules and Regulations reporter. The Center for Medicare and Medicaid Innovation announced last month that it's rebranding the global and professional direct contracting model into an accountable care organization model called ACO Reach. The announcement came after progressive lawmakers and groups pushed CMMI to cancel the Trump-era direct contracting model over concerns that it would effectively privatize traditional Medicare. But value-based care advocates said getting rid of the model would undermine payment transformation work. The new ACO Reach model looks similar to global and professional direct contracting, but places more focus on health equity, increases provider governance requirements, and introduces new risk adjustment policies, among other modifications. Today, we're joined by Liz Fowler, the director of CMMI, to talk about these changes. Liz, thank you so much for joining us.
Hey, Maya, thanks for having me. I really appreciate the opportunity.
We're really excited to talk. To start out, can you walk us through how you decided what to keep and what to change in ACO Reach compared to the global and professional direct contracting models?
Well, I think you spelled it out in your opening remarks. As you alluded to, we announced substantial changes to GPDC, and those changes reflect the priorities of the Biden-Harris administration, and more specifically, an affirmation of the commitment to health equity, to our goal to reorient the model test toward provider participants, and then also to respond to feedback from both participants and stakeholders. And I can go into a little bit more detail into each of these three areas if you'd like.
Yeah.
Well, with regard to advancing health equity, we included a requirement that all participants develop and implement a robust plan describing how they're going to reach underserved populations, and that includes rural communities. There's an application of an adjustment to increase the benchmark for ACOs, serving higher proportions of underserved beneficiaries. And we'll be identifying those areas based on a composite measure that considers area deprivation index and dual Medicaid status to make sure that the benefits of ACOs are available to all Medicare beneficiaries. And then also there's a requirement for all ACOs to collect beneficiary reported demographic and social needs data. And then the second priority is really reorienting the model back toward more of an ACO mold. So CMS is going to ensure that healthcare providers play a primary role by requiring at least 75% control of each ACO's governing body be held by participating providers. And that's compared to 25% in the GPDC model. And then in addition, at least 2 beneficiary advocates must sit on the governing board, and they have to have voting rights. And then third, we're going to deploy a more enhanced approach to screening applicants, more robust monitoring of participants, greater transparency into the model's progress, even before we have results from a formal evaluation. And we'll share information on model participants and what they're doing to improve care.
Yeah, and we'll dive into some of those even more in a moment. But I'm curious, what would you say to progressives and other groups who wanted to see direct contracting thrown out or changed more drastically than you have?
Well, first, I would start by saying that we did, in fact, permanently cancel the geographic direct contracting model, which has been on hold since March of last year. And there was a lot of confusion between the GEO model and GPDC, and it seemed like some of the criticism about GPDC was based on features included in the GEO model. So I hope this step puts to rest some of that criticism. Second, we made important changes that address concerns raised by critics. In addition to the focus on health equity and the shift towards provider-led organizations, we tightened the risk adjustment policy, and I think you mentioned that earlier, and of course the increased monitoring and compliance activities. And then finally, I just want to add that an immediate end to the GPDC or any innovation model could result in care disruption for beneficiaries. Patients served by ACOs can receive care that they might not get under traditional Medicare, like greater support managing chronic conditions, supporting transitioning from the hospital to their homes, transportation assistance, and in some cases, Part B cost sharing assistance. Ending the model would also be disruptive to model participants. And we want to be a good partner, and we want to be a good partner to good actors, including many who have succeeded in prior CMMI models, and they're truly committed to improving care for Medicare beneficiaries, particularly those with high costs and significant health needs. So the bottom line is that we're committed to improving care for beneficiaries in traditional Medicare. Part of that is by increasing their access to accountable care relationships with healthcare providers. And we deeply appreciate all the feedback and comments we've received on the model. We think we landed in the best place possible by listening to all sides. We addressed this feedback as much as possible in the revised ACO Reach. And of course, we will continue listening to stakeholders as we proceed with the new model and make additional refinements as needed.
Yeah. And relatedly, some people have raised concerns that, even with such big changes to a model, CMMI might lose the trust of some participants. How do you plan to mitigate that?
Well, we've got to do a good job of communicating why we're making the changes and the changes we're making. And I'll tell you, we've received a lot of positive feedback about the changes from participants. And this isn't surprising, as a lot of the changes we made were in response to the experience participants had during the first year of the program. And in fact, we've talked to participants in other models who are now asking if we'll consider adding the health equity policies to those models. We value our model participants and understand the effort and resources that go into participating. Our goal is to be transparent with model participants and the general public, and particularly beneficiary groups, as we work to gather important information that we need to improve models over time. And regarding current model participants, I think it bears saying that participants who meet the requirements of the ACO Reach model who are participating today will be able to continue participating. We're committed to value-based care. We believe the infrastructure investments made to date will continue to provide valuable benefits to Medicare beneficiaries and to the Medicare trust funds and participants. So, with all that said, we're going to make sure that model participants maintain a strong compliance record in 2022, and that they agree to meet all the requirements for ACO Reach by January 1st, 2023, in order to continue their participation.
Yeah, and this all will require a lot of relationship building and trust building with the participants, both current and future. Are there any specific activities in that sphere that you plan to undertake?
Well, regarding the monitoring and compliance activities, again, we want to ensure that beneficiaries are receiving the best care possible. It's critical in our view. So we're committed to making sure that DCEs this year and ACOs going forward adhere to the requirements of their participation agreements with CMS. And so doing that involves monitoring and compliance of both GPDC and into ACO Reach. So in addition to reviewing marketing materials, communications sent to beneficiaries, and investigating beneficiary complaints, we'll be using more data analytics to monitor use of services over time and comparing that to a reference population. This will allow us to assess whether there have been changes in beneficiaries' access to care. We'll look annually at whether beneficiaries are being shifted into Medicare Advantage and looking more closely at inappropriate risk score growth. We plan to continue our audits of contracts that ACOs have with providers and learn more about their downstream arrangements and identify any concerns. And we'll monitor for non-compliance with prohibitions against anti-competitive behavior and misuse of beneficiary data. We have the capacity today, and we are ready to carry out these new activities.
And where does the funding come from for these activities? Do you expect this to create any extra burden on model participants?
We don't expect that it will create burden for model participants. It will be more of a burden on CMS. And so we have the data. I think we need to make sure we have the resources and capabilities. We think that we do. We can use some existing resources, and I need to make sure they're not stretched too thin, but we think we have the capacity to do it.
Yeah. And you've mentioned health equity. ACO Reach addresses health equity issues very head on. And I know this is a major priority for CMMI models going forward. So tell us more about how you plan to monitor models' health equity impacts.
Well, I think this is a really important point. And as I mentioned, we're really pleased with the direction of these new policies. And you can expect future Innovation Center models to include features from ACO Reach, like the requirement of a health equity plan. In fact, the ACO Reach, this design really laid a lot of groundwork for our thinking. And we engaged in partners across CMS and HHS to operationalize this model with really meaningful requirements to advance health equity. We're continuing to explore avenues how to increase the number of beneficiaries from underserved communities in our models, in part by increasing participation of providers that serve them. We're looking more closely at the application and selection processes for our previous models to identify barriers and challenges that some providers might have faced in participating. And our findings will inform potential changes. We're also looking at what sort of technical assistance and maybe even financial assistance we can provide to ensure that we have a diversity of providers and a mix of patients.
And transparency is another big goal of the model. And CMMI has said that it's going to share more information on participants in their work even before final evaluation results. So how will that work, and how do you plan to advance transparency in future models as well?
Well, we have done a real, first of all, we started by putting out information on early data from the first 2 quarters of the program on quality and on financial numbers. It's very early, not official, not statistically significant, but I think we'd like to try to find a way to do more of that. I think stakeholders have shown a lot of interest in the model. We want to be able to share more information with the public. And, that also includes model information about model participants, what they're doing to improve care, early impacts, as I mentioned. This type of transparency makes us more accountable to the public, and it can also inform future model improvements. We're also looking at quarterly updates of aggregated information on the model to include things like the number of aligned beneficiaries and preliminary information on quality and financial performance. Again, same information that we put out a couple of weeks ago.
Thanks. And aside from this model transition, CMMI has many other initiatives going on as well. And you've mentioned wanting to engage beneficiaries in CMMI models and in accountable care. How can providers help advance this goal?
That's a great question. And we've been doing a lot of thinking about how we're engaging beneficiaries with our models and where we can do more. And I think the provider community can certainly help in this. A first step is coming up with a common language about what value-based care means. To get a better sense of patients' perspective, we convened focus groups to learn what they thought about the work of the Innovation Center. And we learned that the language and the terms that we use is really not resonating with them. The term accountable care, for example, was interpreted as skimping on care and not providing better or more coordinated care. Patients with chronic conditions might understand the value of coordinated care, but patients with fewer health needs didn't really understand that concept. And the term equity also doesn't resonate with people. So we think the work we're doing can lead to better care and outcomes. We need to be more thoughtful about how we talk about our goals, how we define success, and we think that the provider community can help us do this.
And we'd be remiss not to mention the COVID-19 public health emergency, which we're all so familiar with at this point. The Center for Medicare and Medicaid Services has allowed providers to use certain flexibilities to deliver care over the last 2 years that weren't typical before the pandemic. What role might CMMI play in continuing new care delivery systems made possible by waivers once the PHE is over?
We're having those conversations right now at CMS. It comes back to the question of what is the purpose of CMMI. I believe CMMI should be used to test ideas to make for ways to make the health system better. If we discovered something that worked really well during the pandemic, those good ideas should become a permanent part of the CMS programs. And if there are care delivery flexibilities and innovations from the PHE that increased access to care, then we should consider including and testing them in further Innovation Center models. And we intend to be doing that review and looking more closely for sure.
We'll definitely stay in touch with you on that one. Liz, is there anything else that our readers should know about the ACO Reach model or anything else happening at CMMI right now?
Well, I would refer folks back to our new strategy that we put online and posted back in October. If you're interested in learning more about the direction we're going, we're hosting a number of listening sessions. We've held one on for beneficiaries and patients, one on health equity. We've got one coming up that we've announced on safety net providers. So please continue to engage with us. Our door is open. We want to hear from stakeholders and anyone who has ideas to share, any sort of feedback. We welcome that engagement. So thank you.
Thank you so much for joining us, Liz. Liz is the director of the Center for Medicare and Medicaid Innovation, and we hope to talk more with her soon. And I'm Maya Goldman. Thank you for listening to The Checkup.